Well, good evening and welcome to this OrthoHub webinar on Tuesday, the 8th of March, 2022. Today is going to be all about the ST3 interview for trauma and orthopedics. So what to expect and how to be successful in getting a sought after place in trauma and orthopedic specialty training. My name is James Houston and I'm a post-CCT fellow in orthopedics. I'm also the OrthoHub Education Fellow as part of the BOA Future Leaders Programme. So what have we got lined up over the next hour and a half? Well, we're really lucky to have some fantastic faculty tonight. We'll begin with an overview of the interview process by Mr. Mark Crowther, National Lead for the ST3 selection process. We'll then have some reflections on how to succeed by Mr. Cronan Kerin, current interviewer, consultant orthopaedic surgeon and TPD for Mersey. We'll then go on to have a walkthrough guide and tips from the stations themselves. We're fortunate to have this all by recently successful ST3s who will be able to give you their reflections on what you need to do. Portfolio will be brought by Paddy Lancaster, who's an ST3 in Kingston. The clinical station will be given by Jawaad Saleem, ST3 in Croydon. And list planning prioritisation by Matthew Hague, who's an ST3 in Epsom. Last, but certainly not least, will be Lisa Hadfield-Law, expert educator and education advisor to the BOA, someone who has extensive experience in interviewing. Lisa will be talking about something that you may not have had that much experience in, which is interviewing virtually and how to be successful at it. If we have time, we'll try to have a few questions and answers. But please feel free to put these in the question and answers box throughout the webinar and we'll try to answer them as we go through. Likewise, please don't hesitate to check out some of the other OrthoHub content, as there's a lot of great stuff out there. So we'll move on to our first speaker tonight, Mr. Mark Crowther. I'll now hand you over to him at this point.
Thank you, James. Oh, there we go. Thank you, James. My name is Mark Crowther. I'm the chairman of the Trauma and Orthopaedic Selection Design Group. I'm a consultant orthopaedic surgeon in Bristol. I was the training program director for the registrar rotation for 6 years. I was then invited to join the SAC, and as part of that, I took over the chairmanship of the Selection Design Group, which runs the national selection process for ST3 selection. So we do this as part of the SAC, and we have a subgroup, the Selection Design Group, on behalf of this thing, MDRS, which is the Medical Dental Recruitment Society, section of HEE. And for trauma and orthopaedics, we are led by the Yorkshire and Humber Deanery. And for over 6 years, we had a successful face-to-face interview process in Leeds. And I'm sure you're all aware, the 5 stations which we've moved people in and out of the boxes at Elland Road Football Stadium through the 5 stations for portfolio, including the validation of the self-assessment form with the portfolio, the clinical station.
Mark, sorry to interrupt, we can't see your slides.
Right. Why is that? You should be able to see my slides. Can you see my slides?
Not yet.
Yes or no?
No, not yet, Mark.
Right.
Do we desperately need them, Mark?
Well, you do, yeah. I've got loads of graphs and things. Why is that? Why has that worked so well before?
Just give it one more go.
Yay.
It's
we go.
coming.
Okay, is that better?
Perfect.
We're on your title slide, background now.
Background. Okay, so that's what I was just saying about the 5 stations. Right. So I'm just going to give you a little bit of background. So I took over from what was this very successful situation we had in Leeds with the interviews. And I was taking over what I thought was a fair and robust process. And it had been so well meticulously analysed and improved that we thought we were the envy of many of the certainly surgical specialties, and I think across medicine. And then, of course, what happened in 2020, just as we were about to kickstart the process, the pandemic struck. And then there was a pan-specialty decision from HEE that there would be no face-to-face interviews. We'd suggested that we should just stop everything, pause, and we campaigned strongly just to have lat appointments for 2020. But that was declined completely because everything had to be the same across all medical subspecialties, and NTNs were to be appointed. Now, fortunately, we were the envy, as I say, of many specialties, and that we'd had our robust self-assessment form. But they decided that this was to be used unvalidated for the process in 2020, simply because nobody knew quite what the demand on orthopaedic surgeons, orthopaedic consultants in particular, to perform the process that we wanted to do to validate self-assessment and to perform the interviews. The careful decision was made with reference to the previous year's data, and we do hold the data for all the years going back, that with a maximum possible score of 32, the appointability score should be 21. And this was on the self-assessment form, and this predicted to carry a reassuringly low risk of appointing somebody who was unappointable. But with a threshold score of 20, the risk would have increased, and by 19, that would have increased considerably more. So we had a very difficult decision to make, and lots of us over, of course, video meetings and telephone calls late at night. The chairman of the SAC was on his holidays in the Far East at that time, and the disruption was extraordinary. And we estimated we'd have just over 100 appointable applicants on those criteria for 2020. We didn't at that stage know what the TPDs would declare, given that suddenly most people's post-CCT fellowships were going to come crashing to an end, and they would have to probably stay in this country. If we compare that with what had been normal the year before, in 2019, the maximum possible score for the whole interview process, the whole selection process, was 302, with an appointability score of 190. Now, last year and this year, we're going to have a maximum possible score of 182 with an appointability, and I'll come to this later, of 112.5. In 2019, the lowest self-assessment score to be appointed was 9, who had a final total of 219. And the same year, the highest self-assessment score to be unappointable was 20.5, and 2 of those applicants had final totals of 183.5 and 179.5, below the appointability score of 190. Now, 2021, last year, we offered interviews to 358 applicants, and the lowest self-assessment score in that was 15.67. So in 2020, we had our 12 self-assessment questions, which are exactly the same as they are now, essentially. They were ranked for tiebreaker purposes, and I was only asked to adjudicate on a single pair of tied applicants. And when it came to results day on the 22nd of April, there was an administrative error which only released 52 offers, and that was promptly identified with complete panic all round. And with HEE apologising, there was a quick resolution, and finally that resulted in 107 appointable offers. Given that we'd predicted 105, that wasn't bad. Now, last year we had 604 applicants, and once we'd longlisted some for work visa reasons and legalities of employment, we then had to look at all those self-assessment forms which were validated, and all those of you that may have been involved in that would have uploaded your evidence for the self-assessment forms. We then had the capacity to interview 360. Now, I wrote to the lead for recruitment at MDRS and said that we were happy to interview as many as applied, and we could have done that, but it's just logistically impossible. 335, that's 94% of those, met the appointability threshold. And at the end of the day, 177 ST3 posts were offered. The lowest rank offer accepted was 193. So out of our 358 actually interviewed, the lowest ranked person that got an offer was 193. Just compare that to previous years, and this is all the way through all the process in Leeds. And this is a very busy slide. And you can see as we get closer to this year, we've had over 500 applicants this year. But you can look at the percentage, the appointability percentage, which has varied along the way for a variety of criteria. And the number of posts, of course, has varied along the way. And I'll come to that a little bit later. What does that look like graphically? Well, we're still popular. We were worried that applications were dipping for several years, but they've gone up and up and up again. And there's a variety of reasons for that. Dipped down very slightly this year. And those are the number of interviews we've performed, and those who are appointable and those who are actually appointed. So the total applications per year has changed over the last few years, as you can see by this graphic. And the number of posts, and hence the number of people that were successfully appointed to those posts, are shown in blue. And obviously, we don't know what that's going to be this year, but we've still got we're still a very popular specialty. There are some new surgical ST3 posts this year by region, and so we're in this group here. We've been given 18 new posts around the country. Now, this is perhaps for reasons of need. The Northwest and the Southwest. The Southwest and Wessex don't get any. So there we go. That's where we are. London, Northwest, Northeast, Southwest and Wessex don't get any at all. But Yorkshire and the Humber, West Midlands, East of England certainly have done very well out of that. Thames Valley and KSS. So there are more posts around for the first time in a very long time. So where are we so far? From last year and then this year so far? We've managed to validate the self-assessments. And this is a massive process. You've got to understand that everything that we've taken extremely seriously to make sure this continues to be a fair and robust system. We validate the self-assessment forms to rank the applications. People might like to call this shortlisting. We sit literally 20 of us over 2 or 3 days on often 3 screens in front of us, look at all the uploaded evidence. And certainly for 2021, that was 571 applicants looking at evidence for the 12 questions, which was nearly 7,000 bits of evidence for questions. And there's a lot of evidence uploaded for each question. We then rank those applicants, and some of you may well have appealed. We then look, and several of us sit in front of screens again for another day and a half, looking at every single appeal and looking at whether there have been mistakes or what the reasons behind that were. And last year we had 433 appealed questions, which is only 6.3% of the possibles. And this year, obviously, 290 applicants, so 290 people that had appealed for at least one or more questions. Last year, 54% of those appeals were unsuccessful. We were well aware of the change.org petition saying stop shortlisting in ST3 T&O applications. Well, that was fairly short-sighted, really. We weren't shortlisting. We were simply ranking people on their own evidence submitted for their own self-assessment, which is what would have happened. You would have been validating your self-assessment forms in a face-to-face interview. I went to as high as I could to say that we would like to interview everybody, but that was a decision made far above us through MDRS and HEE. And then I've had further emailed complaints, which we've had to address on an individual basis. So this is a process that we take very, very seriously. The HEE decision, despite our appeal, was to limit the interviews to 360 due to the administrative constraints. The video interviews last year were in March, the early April this year. We've had an amazing response from the consultant body of interviewers who do pull out all the stops to sit in front of some screens and be involved in making sure that we are looking for the best people to come forward as ST3 registrars. Once again, we'll have 10 online panels, 3 consultant interviewers in each panel, including with members of the selection design group, which number 18 in total, with admin support for each of those stations. The online platform is secure and it worked relatively well last year. It's not ideal. I was promised that HEE were piling money in that had been saved into a new online platform to have multi-rooms that people could move between a room as if they were doing so in Leeds. This is just not good enough at the moment for us. And I can't envisage how it's going to be robust enough for interviewing 90 people over 4 days each. We will still have the 3 10-minute stations. We've had to do away with 2 of the stations for obvious reasons, but we're going for the portfolio, the clinical, and the prioritisation type station again. And this looks at 2/3 non-technical skills and 1/3 knowledge. The question stations, as I've just said, there's no technical skills and there's no communications with actors. We can assess communication on those other 3 stations. Technical skills, we have looked at the possibilities of doing things over video links. It's really not good enough. They're out. The appointability, I just want to touch on this. You'll be scored individually by 2 assessors. So the two that aren't asking the question in your station will be scoring you independently. And these are people that are, experienced in this. And then you'll be ranked with the overall scores, and the overall appointability score is 112.5 out of 182. And I'll show you how that comes about. This is the matrix as to what you're being assessed on. So down the left-hand side of the stations, the self-assessment, which is out of 32, and then the portfolio station, clinical and prioritisation station, and then it comes up with this final score of 182. And that shows the technical and the knowledge in the pie chart. So the appointability, I'll zoom in on that. That's getting an average of 3.25 per question, i.e. 6.5 out of 10 possibles. And there's 50 marks available per question. And for the 3 questions, so you can get 15 times your 36. Sorry, it's 15 times the 6.5, which is the twice the 3.25, plus the 15, which is the mean self-assessment, gives you 112.5 as the appointability score. And that's the same formula that we've applied in previous years when it was out of 302. In the event of tied overall interview scores, the individual station scores in the order below will be used to differentiate. You'll have seen this because it's in the candidate handbook. Total interview score, followed by the clinical, then the prioritisation, then the portfolio, then the validated self-assessment score. All interviewed applicants are scored, checked, and it's double checked. We challenge if there's been some very significant errors between the scoring, and we're looking at that from afar and keeping a very close eye on all interviews going on in real time. And then all interviewed candidates are then ranked, and Oriel will produce the offers as they do per the ranking and the geographical preferences. And then, as I'm sure you know, you have 48 hours to accept or reject a post. I'll just highlight this, which we put in a couple of years ago. And this is a matter of great concern to TPDs and the SAC. If you're successful in trauma and orthopaedics ST3 recruitment and accept an offer of a post, it is expected that you will honour your appointment, commit to that regional programme, and complete the 6 years of higher surgical training. And whilst the IDT process is available through the national team for legitimate and well-documented reasons, such situations are for exceptional cases only and not for convenient geographical location. The TPDs feel very strongly about this. What the future? Well, we desperately hope for a return to face-to-face in-person interviews for all long-listed applicants, just as we've done before. I don't think that'll ever happen. I think we may be in a situation where we're always ranking people on validated self-assessment. And the last 3 years has highlighted a few areas that are in need of clarification, and particularly on the self-assessment form. I'm quite aware of the trouble that particularly collaborative papers and audits have caused, and we must make this much more robust. And unfortunately, this needs to be acted on almost immediately. This process is finished, that we have to get ready for the following year. But we still believe that we have a fair and robust process that is the envy of many others, including in surgery. Thank you very much.
Brilliant. That was really, really helpful, Mr. Crowther. Thank you so much for giving that talk. Really interesting to hear all about the different numbers. Does anyone have any questions? We might have time for a couple before we move on. Please feel free to put it in the Q&A box.
We'll keep it open.
Yeah.
Why
don't we move on to Mr. Kerin? And if anyone wants to ask any questions in the time period, then please feel free, and Ms. Crowther try to answer those as they come up. Mr. Kerin, thanks so much. Floor is over to you.
Thank you very much. As Miss Hadfield-Law will tell you, I always look miserable on these things. So please excuse me, I'm not quite as miserable as I look. So my remit here is general interview advice, and I'm going to start at the beginning and then work my way through. So I've been on Selection Design Group for 5 years. As part of that, I've helped design some of the questions. I've also been involved in the Q&A of the process on quite a number of occasions, and have interviewed or been involved in interviewing every single year since the process started. So I'm going to start talking about the self-assessment. So assume nothing. Okay. One of the appeals that I went through said I assumed that this would be the case for every single one of their appeals. What they hadn't done is they actually read the advice in the handbook of how to apply. So, for example, for the logbook, if it's not signed by someone, it's not validated. So it asks specifically for a validated logbook. So don't just assume because it's on the e-logbook that it's automatically validated, because it's not, because anyone can upload any cases onto there. Probably the most important piece of advice for anyone going through the self-assessment is make life easy for the person looking for the evidence. Mark's already mentioned about the collaborative papers. Some of them have hundreds and hundreds of people attached to them. And do you really expect someone to wade through all several hundred people looking for your name? That's not going to happen. So lots of people would print off the full name and highlight their name and upload it. Other people would go into PubMed and just put their name in. And actually, during this process, it taught me something that I didn't know before, that even if you're a collaborative author, if you're named as a collaborative author, you put your name into PubMed, that will show up. And then they would screenshot that page on PubMed and upload that as the evidence. But when you've got a short period of time to go through so many applications, you can't really expect people to trawl through stuff looking for a needle in a haystack. This is really important stuff. So you need to make it easy for the people to find out how good you are. The other thing, and this goes back to the assume nothing, sense check what you think you should be putting on to your self-assessment in terms of the evidence. You're about to hear later on this evening from several people who've been successful in the past. So if you follow what they did, you're likely to be successful as well. And most hospitals have consultants who are either actively engaged or have recently been engaged in the process. So they'll have been interviewers, there'll have been people involved in the shortlisting. These are the people that you should be seeking out to just sense check what you're doing is the right thing to do. Pre-interview. There is a very in-depth document that tells you all about the application process. Mark's shown you the appendix at the end already, and I'm going to show you again about how the scoring's done. You need to know that document inside out. And as with all important things in life, you need to practice, practice, practice. And there are bits you can practice for more than others, and we'll come on to that in a little while. So just general things with the interview. There is nothing more infuriating as an interviewer to ask a question and then have a completely different question answered. So that's why it's important for you guys to listen to the question. If you don't quite understand the question being asked, then ask for a point of clarity. but you must make sure you answer the question that's being asked. What the interviewers have is they have a scoring matrix to score you off that's based on the question being asked. So if you answer a completely different question, you can't score as well. And remember that the whole point of the interview is to see how good you are at giving information, and throughout the interview, how good you are at gathering, assimilating, and giving information back. So the portfolio station is really designed to help you guys sell yourself. So this is a real opportunity for you to use it. Okay, probably the best example of this I've seen was someone who had set up a baking business part-time, and they had pictures of it in the back of their portfolio of cakes, etc., that they'd created. And so when they were asked what they were most proud of in their portfolio, they were able to talk about setting up the baking business, how that showed leadership and initiative, and were basically able to use setting up the baking business and mapped it to the personal specification and the scoring matrix so that they were able to hit all the points. And they scored massively. They did so well that at the end, one of the interviewers said, well, the only way that could have gone better was if you brought some cake in for me to try. So it doesn't have to be medical, but there will be an opportunity with the way the portfolio questions are designed for you to show that you're up to date, you're engaged in having a career in orthopaedics, and you'll have the ability to sell yourself. And that's where I go back to reading the personal specification. So if you do get sent something asked something slightly from left field, if you know the personal specification and what people are trying to get out of you in the interview, you can mold your answer to score all those points. The clinical, these are all common scenarios. They've not changed since I was applying to be a registrar at the turn of the century. Mr. Akhtar did point out to me that it was actually the turn of the millennium, but that used up too many letters and I couldn't really spell it. So we know roughly what you're going to be asked. You know, the orthopaedic emergencies haven't changed. Cauda equina, open fractures, compartment syndrome. I got asked about open fractures and cauda equina in my registrar interview. This is arguably the easiest station to practice for because there's only a set number of things you can be asked. And remember, you can't be asked anything that's not in the core curriculum. So you can't get anything that's too esoteric or too advanced. It has to be in the core curriculum. Prioritization. Probably the most important thing is to realize that there's no correct answer. This is about your ability to demonstrate judgment under pressure. So this really is where your information gathering, assimilating it and giving it back under pressure comes in. Last year, someone deconstructed the question so well that they scored the maximum points. And I think that's the first time that I've been aware of where someone's done that in the prioritization station. So by thinking slightly outside of the box, when they were asked, you need to put a list together, they said, right, well, there are some cases on this list that need to go elsewhere that shouldn't go on this list, and came at it almost through the back door and deconstructed it to such an extent that the interviewers are left saying, wow. With this, it's where it is vital that you listen to all of the information that you're given. Make sure you understand the information that you're given and then use it to make informed decisions, so that you can argue what case goes first, what case is going to fall off the list. Are you going to look to put something on an elective list? All this sorts of things. So I'm going to leave you with this, which for me, I think is probably the most important slide here, because it goes back to my original point about knowing what you're being assessed on. if you know that the portfolio is looking for career motivation, learning development, a bit of academic, leadership, team involvement, organisation and planning, and you get asked a question that you're not really prepared for, if you can bring those elements into it, then you're going to score well, even if it's not a question that you've prepared for. That's me.
Thank you so much, Mr. Kerin. Really appreciate your words on this topic, which obviously causes a lot of anxiety to people preparing. So that's given us a really clear understanding of what to do and how best to prepare. So some people have been typing in questions into the Q&A. I think that's been really helpful. Mr. Crowther's been answering some of those as we go on. So I think what we might do now is, if I could encourage you to continue to do that, if you have any questions, then we can continue to answer them and then also continue with the next talk. So Paddy Lancaster is next up. He's going to give us a talk about the portfolio station. Over to you, Paddy.
Thanks, James. So let me just get my slides up 1 second. So hopefully that's come across now. I'll just go full screen. There we go. Yeah, so my name's Paddy, as James said. I'm an ST3 in Southwest London. So I was in your guys' shoes last year facing the interview. So I know how anxiety inducing and nerve wracking it is, but hopefully talks like tonight will just give you some idea and settle those nerves a little bit. So I'm going to talk to you about the portfolio station. So it's a 10-minute station. This is what we're going to go through. So what the station is, some tips, how to prepare, how I prepared. It's not the only way. Obviously, you'll find your own way to prepare as well. Structure, how to structure your answers. I'm sure you're all aware of sort of the camp structure, and we'll go through that, and the star structure as well. Run through potential questions. These are ones that I prepared for last year. There are numerous ones. And then we'll go through a worked example. I personally found this potentially the hardest one to prepare for, because it's so broad. They can essentially ask you anything. It's not like, as Mr. Kerin was saying, with the clinical station, where you know you can be asked about an orthopaedic emergency. This, they can ask you sort of about anything. So station is 10 minutes. It does go really, I mean, the whole interview goes really quickly, but each station goes very quickly. It's 2 to 3 questions. I think I got asked 3 questions last year. It's likely something motivational. Tell me about your career so far. Why do you want to do orthopaedics? And then there'll be 1 or 2 sort of other questions, which I hadn't really prepared for mine last year. I sort of thought about similar things, and I think it's designed to make you think on your feet and see how you answer it. And if you just stick to a good structure, hopefully you'll get across the points that you wanted to. So I had a big book that I wrote down examples of common scenarios. So example of leadership, example of good communication. Think about these things. Think about what you've done at work, when you've had a good teaching experience, when you've had a bad teaching experience, and write them down, and write down answers to common questions. So the motivational questions: why do you want to do orthopedics? Know what you're going to say. I'm not someone who likes to sort of write down verbatim what I'm going to say, so I sort of bullet pointed, but you just got to do what worked for you. I think the problem if you write down a script almost is, as Mr. Kerin said, you won't necessarily answer the question. You've got to relate everything back to the question they ask you. So if they ask you why you want to do orthopedics, or tell me about your career so far, you're going to be saying a lot of the same stuff, but you've got to relate it back to what they actually asked you. Structure is so important. I know when I first started preparing for these last year, I'd often ramble a little bit, and then I actually started structuring my answers a lot better. And then summary at the end, I think, is really useful, because it shows the interview that you finish the question, you relate it back to the question, what they asked you, and you're ready for the next question as well. There's not a massive amount of knowledge-based stuff in here, but you know, I think the new curriculum, I know probably most of you are CT2s and still on the old curriculum, so know about the new one. The capabilities and practice and the generic professional competencies, know about them and how the curriculum's changed this year. And clinical governance, but what's your role in clinical governance? Don't just reel off the 7 pillars of clinical governance, but how does it affect you? Try and back up your answer with evidence. Obviously, it's not hard evidence, but it's, you know, if you say, I have done 15 DHS operations, this is evidenced by my validated logbook, or I've taken part in X number of fracture clinics as evidenced by work-based assessments. So just gives you a bit of gives you a bit of evidence to back up what you're saying. And it's all about selling yourself. We're not always very good at that. Sometimes we sort of undersell ourselves, and it's trying to find that balance of selling yourself, be confident, but don't be arrogant as well. Think about what your USP is, your unique selling point is. As Mr. Kerin mentioned, that person who ran a bakery, that's obviously something they thought about and wanted to get into their interview. And everyone has something unique about themselves. What do you want to get across to the interviewers? And as has been mentioned numerous times, practice, ideally on Zoom/MS Teams, because it is different than doing it face to face. And it's personally, I find it harder. I like talking face to face, but we're dealing with what we're dealing with. So practice with each other. If you've got some nice consultants, registrars, I was very lucky that some practice with me. So try and take that time to do that. I'm sure you know about the camp structure, so I'm not going to spend too long on it. But what I think is really interesting, I looked at my feedback and obviously the marks in preparation for this, and obviously the mark scheme's been flashed up a couple of times, and it basically follows a camp structure almost. So clinical is sort of your career, motivational, learning and development. There's an academic section. Leadership and team involvement is your management. And then the personal bit's just quite nice to show them it's not all about work with you. With the clinical, focus on your orthopaedic experience, operations on calls, what fracture clinics you've done. And as I mentioned, try and evidence things with a validated logbook, work-based assessments to show you've taken feedback and listened to it. Most people's CVs are either more teaching or more research. Mine personally was more teaching. So I focused on that. I think if you try and get in teaching and research, you might sort of give a half answer to both. So I think focus on what you're best at, but then you can also mention the other thing at the end. Management, I didn't have a formal leadership and management role. So I sold sort of a service development project where I'd introduce an electronic op note in one of my trusts as leadership and management. So it's how you sell things as well in the interview. And then, like I said, personal. It's just nice to get a personal touch in. And then I think at the end, summarize. So go back to the question, what they asked you. So you're not just reeling off all this stuff. And it just shows that you're ready for the next question as well. STAR is more for, if you ask for, give me an example of the teaching scenario, give me an example of a leadership scenario. So you lay out the context of the situation, you talk about what you're trying to achieve, what did you do? And then probably the most important thing is reflecting on that. So what was the outcome of what you did and what would you do differently next time? So that's just more important for when you're trying to go through a scenario, if they ask you something about, leadership, communication, etc. So I just had to sit down, think about what sort of things therefore last year I had a look through what I wrote down. I spoke to some of the registrars as well. So you're going to be asked to be something motivational. Why do you want to do orthopaedics? What would you bring to registrar training? They're essentially the same question. So you follow that camp structure, but then you've got to relate it back, as Mr. Kerin said, to what they actually asked you. So don't just give the script that you prepared. You've got to tweak it a little bit to relate it back to the question, even if you're getting the same points across. Scenario questions. So tell me about time you've seen good leadership. So like I said, have some ideas of scenarios you can get in. And obviously, like good leadership and good communication are often the same thing. So you don't need a scenario for every specific thing, but have some scenarios in your head you could pick and use for different topics. And the knowledge-based questions, so we've mentioned them already. And then there's more sort of miscellaneous. And it's good to practice with each other and think of sort of strange questions to ask each other just to see how you respond to that and how to think on your feet. So I just thought of a few there, but of course there are sort of many other different things you can prepare for. We're going to go through a worked example. So why do you want to go into orthopedic surgery? They're going to ask you something like this, okay? And this will probably be the first question in your portfolio station. And this is your chance to sell yourself and get that confidence but not arrogance across. So I've been interested in orthopedic surgery since, I was in a rotation in medical school. I did it on elective. Find the first time that you really started getting into orthopedics. Talk about what you've done so far. Talk about your operative experience, your fracture clinic, your on-call experience. And then personally, I said, because I enjoy it, I really enjoy the challenge it poses on a daily basis. Talk about your research or teaching and relate it back to the question though. Don't just, if they ask you why do you want to go into orthopedic surgery and you say, oh, I've delivered X number of teaching sessions, that's not answering the question. So you want to continue to build upon that during your registrar years. Talk about, again, management, but again, everything's got to go back to the question. There's a different scope of different management roles within orthopedics, and it's something you'd like to get involved in later down the line. I mean, there's not too much personally, but in this specific question, if you say, tell me about yourself, then obviously you can talk about whatever you do, whether that be art or sport or whatever. And then summarize. I think summary is really key, like I've been saying throughout this. Summarize what you've mentioned, and then finish on something positive. You know, they've asked you why, you know, you're looking forward to your registrar years. So ultimately, I want to go into orthopaedics. I really enjoy the specialty and the challenge it poses on a daily basis. And then, you know, they're ready for the next question then. In summary, confident and sell. This is your opportunity to sell yourself, as has been said. I think Mr. Kerin mentioned that. Sell yourself, okay, but try not to be arrogant. So confidence, not arrogance. Structure, I think it's all about structure in your answers. And if you stick to that camp structure, especially, as we've seen from the marking sheets that have been put up by earlier in the session, you will take most of them boxes. So stick to that structure and then summarize at the end to show that you've answered the question and you're ready for the next one. Thank you very much for listening. I don't know if there's any questions popped up at all, but if anyone wants to email me anything, ask anything, then I'm very happy for that as well.
Paddy, that was brilliant. Thank you so much for giving that talk. Nice, clear explanation of some of the things that could come up during that station. So I'll now hand over to Jawaad Saleem, who can tell us a little bit more about the clinical station. Do please keep asking any questions that you have in the Q&A box, and we can continue to answer them as we go forward. Over to you, Jawaad.
Thank you, James. So yes, as James said, I hope you can see my slides. My name is Jawaad and I'm one of the current ST3s on the South West London rotation with Paddy and Matt. So I'll be taking you through how to prepare for the clinical station. This is an outline of the presentation I'm going to be going through. So first of all, I'll talk you through what the station outline or the format is, then what material to learn and prepare. I will go through some interview scenario examples so that you can get a flavour of the type of questions you might be asked. And at the end, I'll take you through some personal tips of mine of how to prepare for the clinical station. So the station outline, as you know already, it's a 10-minute station and there's 2 scenarios. So previous cohorts may have had more stations to be tested on a range of topics. In this situation, you've got a 10-minute scenario, just as everyone else does. So really, every question and answer is going to be crucial. So you need to be impactful, you need to be systematic with your answers and really demonstrate your knowledge. And we'll talk through how you can do that by structuring your answers well. So what to prepare for? So I've split this into 5 key domains. You've got your ATLS and trauma. You've got your Boston NICE guidelines, your anatomy, your case-based orthopaedics, and I'll explain more about that later on, and then some of your operative principles. So in terms of ATLS, so ATLS is a really common scenario. Some of you may well be familiar with it from your core surgical training interviews, where you would have gone through a number of those sort of clinical ATLS scenarios. Now, this is no different. You need to learn your ATLS student course manual very well. So you need to be able to manage your C-spines, your airways, your resuscitation scenarios. And as Mr. Crowther has mentioned, these are really common scenarios that will come up. So what I would advise is you have an ATLS spiel to hopefully set a platform for your answer. It's up to you how you do that, but an example I might give would be due to the high energy mechanism of injury, I'd manage this patient using ATLS principles. This is an MDT approach that includes a C-spine plus A to E assessment. Assuming this patient is resuscitated, stable, and this is an isolated injury, I would go on to take an ample history, provide analgesia, and then focus on the injury presented, ensuring that it is a closed, neurovascularly intact injury, and then no signs of compartment syndrome. So that sort of example spiel just helps set up the answer. It signposts the fact that you're trying to be safe, you're thinking of life and limb threatening issues, and that you're thinking of some of the potential scenarios that could be happening. However, as I mentioned, you need to be adaptable to the scenario that's been given to you. So if you feel like this is pushing you down a resuscitation scenario route, you may well be pointing out some of the aspects of that student handbook and some of the things that you'll be thinking about in the management of that patient. ATLS is common, it comes up, and you need to know it well. Secondly is your boast and nice guidelines. Now, your boast guidelines underpin a lot of the management that we perform on a day-to-day setting in trauma patients. You'll find them on the BOA website. There are at least 15 of them, and they look into the management of ankle fractures, distal radius fractures, pelvic injuries, and it's really important you know them well, because a lot of the content of them provides a lot of the answers to the questions you'll be given. How I would look at it is, I would imagine someone's asking me to take them through the BOA guidelines for the management of distal radius fractures, and then I would have a spiel prepared that focuses on just the pertinent aspects, particularly of that case, because a lot of that is what you will need to be demonstrating in the interview. Yes, there are a number of guidelines. Don't be daunted on how many there are. A lot of them share core principles which are reflected in each other. So, for example, documenting neurovascular status, referring to a specialist tertiary referral centre if appropriate. So don't be daunted by how many there are. A lot of them have shared principles. NICE guidelines, particularly in regards to hip fractures, are going to be very important for you to know. And a really key aspect is incorporating these guidelines into your answer early. So you're signposting to the interviewer that you know them, and then of course demonstrate your knowledge of them. And that's what I mean by having a basic understanding of the pertinent aspects of them, of each of them, so that when you're in that scenario, you can just reel off, not bullet point fashion, but reel off the important aspects of them. In terms of your anatomy, I use my MRCS anatomy notes. I think it's a really good foundation for the questions that will come up in terms of anatomy. One added aspect is the approaches. So you will need to know your basic approaches, for example, to either the hip, the ankle, the forearm. And I think an Excel spreadsheet as an aid memoir is quite a useful way of learning them. So your approach, the position, some of the structures at risk just helps ingrain in your memory, if you get asked on them, a systematic way of demonstrating that you know those approaches. Diagrams, so cross-sectional anatomy, a picture of any bone or anatomy can come up. So it's worth having basic understanding and an overview of some of those diagrams, and I think that will help you if it does come up. So this is what I mean by case-based orthopaedic. So there are a number of potential scenarios that can come up, and I think you need to know your basic assessment and management of those scenarios. So, for example, an upper limit may well be a shoulder dislocation, and the lower limit may be a hip fracture or an ankle fracture dislocation. Spine may be cauda equina, peds the limping child. So you need to know a well-rehearsed way that you manage these patients, and be able to discuss them clearly, because as an SHO and then as a registrar, you will be dealing with these cases. So a really nice way of you will need to have a nice way of just presenting how you would manage them. Within those specialities, you'll need to know some of the classifications and also some important papers. Now, I'm not suggesting you go and memorizing every single paper that you've heard of, but we practice evidence-based medicine. So to be able to display an understanding of the rationale and the evidence for the decisions that we make is really important and useful, and will really flesh out your response and answers. So it's certainly worth having a look at some of those papers. So in terms of operative principles, now, as Mr. Crowther says, this is slightly less relevant than it was in previous cohorts. However, these are things that you'll be doing on a day-to-day basis as an SHO, whether you're performing or assisting these procedures. It's worth just rehashing and rehearsing how you might talk through some of the operative principles behind a case that might come up, or some of the AO principles. Again, it just demonstrates a deeper understanding of how we manage patients in theatre, and it's something that you do on a regular basis. So keep them in the back of your mind in case the opportunity to discuss those principles comes up. So a couple of quick interview examples. This is a really common scenario. So you may well be presented with a young gentleman who's been struck by a car, and you've been asked to manage them in A&E. So the question may be, take me through your management of this patient. Now, the key aspects you need to be thinking and flagging in your head is, this is an ATLS scenario, so I need to have my spiel prepared. This is an open fracture, so I need to highlight that early, and then that will help set you up for the rest of the scenario. where this scenario could go, they could focus on certain aspects of the BOSE guidelines. So what are the key aspects which dictate the timing of when we operate on this injury? They may well take you through compartment syndrome or the anatomy of the lower limb. So by setting yourself up nicely with knowing the core common presentations that can come up, it can help dictate how the rest of the viva goes. This second example is a supracondylar fracture. So you may be asked to describe an X-ray. So you need to have a systematic approach in how you're going to describe one. Again, highlighting both guidelines again in terms of the super management of supracondylar fractures or neurovascular injury is going to be important. So again, guidelines are going to be important, and then later on it may well be the anatomy of the elbow. Just these two examples can give you an insight into how the interview may go and what you might be asked on. So in terms of my personal tips, personally, I would suggest this is a really important interview, as I'm sure you're already being told and feel. But so you should give yourself enough time to prepare. So you prepare for it like an exam. However, you need to focus on the high yield common topics that are going to come up: your open fractures, your compartment syndromes, your BOSE guidelines, and that will help give you the core knowledge that you need to tackle any scenarios. Whilst I do say prepare like an exam, it's not an exam. The interview is not an exam, though. It's a conversation. You're discussing some of the orthopaedic principles that you encounter on a daily basis, and you want that to come across in a nice, systematic, evidence-based way. So that's important to try and you're not blurting out guidelines, bullet point style. You are having a conversation. So really keep that in mind before you have the interview. Question banks are good for content, for your papers, for your classifications, for your case-based orthopaedics. Courses are useful because they can set a good platform for the rest of your interview preparation. And I think mock interviews are useful, especially towards the end, for good feedback on how you're getting on. Peer-to-peer learning is always good in terms of vivering and discussing what things you might be unsure of, and really reach out to your current registrars to help test you, because they know what to expect and they can really give you good feedback as to where you are and give you mock interviews. And don't discount trauma meetings. They're really important learning points on a daily basis. So the common scenarios that come up in trauma meetings come up in the interview, and also ask your consultants whether you can be vivid on a particular case that's come in that morning. So those are all some personal tips of mine, and feel free to ask any questions. So best of luck to you all, and good luck in your interview.
Thank you so much, Jawaad. That was really, really helpful to hear your advice on the clinical station. Going through common topics first is just perhaps the thing that I take away from that. I'd now like to hand it over to Matt Hague, who's going to give us a highlight of the Prioritisation Station. As mentioned before, please don't hesitate to put any questions that you have in the Q&A box. All of the faculty have been answering those as we've been going through. Matt, over to you.
Thanks very much, James. Good evening, everyone. So my name's Matt Hague. I'm ST3 on the South West London rotation. I'm going to talk about the Prioritisation Station for the next few minutes. So this station asks you to prioritise cases in one of two scenarios. You've got 10 minutes to either plan the next day's trauma list from a list of possible cases, or prioritise how you would approach a list of patients referred to the on-call team. Unfortunately, I don't have time to talk about them both today, but you can certainly apply the principles of the list planning exercise that I am going to discuss to the on-call scenario as well. So you'll need to gather relevant information about the cases, which will help you decide which need to be done and in what order. It's important to ask enough questions to show your knowledge, but not so many that you don't finish. 10 minutes, as some of the other panelists have been saying, really isn't very long, and the station will really fly by if you're not careful. As part of this, I think it's useful to give a running commentary of your thoughts about each of the patients as you discuss them with the interviewer, as you might not have time to fully summarise each one at the end. Towards the end of the station, if you haven't volunteered it already, you'll be asked to give an order of how you would approach the patients and justify your answer based on the information you've collected. I think time practice is really important with this station. So you need to get used to talking about the patients on the list and the questions that you need to ask, and making sure while doing all that, that you can keep to the time that you'll have in the station. So here's an example of an operating list that you might be asked to order. So given the virtual nature of the interviews, I think you can probably expect it will be displayed on the screen, kind of like I'm doing now, as you're doing the station, and you'll be able to talk through each of the patients with them in front of you. So there's some general logistical information that you'll most likely be told as part of the introduction to the station that may affect some of the decisions that you make in your list order. So what setting you're in matters, as a district general hospital and a major trauma centre will have quite different setups and specialties available to them. You need to know what theatre time you have available, whether that's 1 or 2 lists, a half day or a full day, and so on. It's useful to know the subspecialty of the operating surgeon, as this will affect the kind of specialty cases that they're prepared to do on the list that you're planning. It might be good to ask if there's any extra capacity for you to use, so such as on the CPOD list, or cancelling elective cases if there are too many cases on the list, because it's pretty likely that there will be too many. X-ray might be available all day or for part of the day. This will affect where in your order X-ray cases are allocated. So you should then go through each case in turn, gathering information which might help you decide how to prioritise the cases. So this includes factors that may help you decide if a patient's ready for an operation, such as being medically optimised or having kit available to do a complex case. Urgent factors would include if a patient should be operated on earlier due to an emergency reason, such as signs of sepsis or neurovascular compromise. Prioritization factors might help you decide if one case should be done before the other, such as thinking about BOSE guidance for ankle and wrist fractures recommends they're done within a certain time scale, or for example with hip fractures, ensuring that that fractured neck of femur patient who was admitted earliest should have their operation earliest, as it reduces their risk of morbidity and mortality associated with their risk with a hip fracture. Some factors may help you decide which operation is required if it's not listed. So an example would be if a patient is listed with a displaced intracapsular neck of femur fracture, you might want to ask about their AMTS, their comorbidities and mobility aids to determine, according to the NICE guidance, if they might be more suitable for a THR or a HEMI. Finally, there is a possibility that you might be asked by the interviewer to give an example duration of a common trauma operation, so a DHS or a HEMI or something like that, to ensure that you understand how many cases could actually fit into a day's operating. So when you're asked to order the list, you should consider putting cases like this earlier rather than later. So life and limb threatening issues go first, followed by open fractures. You should know the both recommended timings of when open fractures need to go to theatre. Intracapsular fractured neck of femurs that are going to be fixed, so usually in younger patients, should have their operation more urgently to protect their blood supply. Children tend to go earlier if possible, as it isn't great to keep them starving all day. And neck of femur fractures should ideally go earlier, as if they're unwell post-operatively, it will hopefully be during the daytime when there are more people around to manage them. Diabetics on insulin ideally shouldn't be fasting all day, as they can go hypoglycemic, and they should be on a sliding scale if they are fasting, again, to prevent that from happening. Finally, patients with a latex allergy are better operated on at the start of the list, as otherwise, if they're operated on after a case which has used latex, there has to be a delay to wait for the particles to settle before you can proceed to avoid the patient having an allergic reaction. Patients who are more likely to be operated last are infected cases, as you want to avoid spreading the infection to the uninfected cases. Then kind of other cases that might be lower on the priority are non-urgent fracture cases. They may need to be cancelled if there's not enough capacity on the list. And finally, if there's a patient at home, it might be better to do an operation on a patient who's in a bed so that that patient can be discharged rather than bringing someone in. But it all depends on, obviously, other clinical prioritization factors as well. So going back to our example, as I go through each of these, have a think about what you might want to know about each patient, and I'll put up the information that is available. So for general information, we've got an all-day trauma list at a district general hospital. The consultant subspecialty is upper limb. There's X-ray available all day, but no extra capacity for operating on the CPOD or elective list. So you have one list and that's all you've got. So the first patient is a 70-year-old displaced intracapsular neck of femur fracture. So for her, we need to know when she was admitted, if she's medically fit for the operation, and given that we're not given the operation that she's going to be having, we should use the AMTS, her comorbidities and lack of walking aids, to conclude that she'd probably be a candidate for a total hip replacement. We should then ask, and using that information, if there's a hip surgeon available to do a total hip replacement. Otherwise, the lady might have to wait for one to be available, but fortunately there is, so we can proceed with her on the list today. The next case is a 25-year-old clavicle fracture in a high demand patient. So we can recognize that this patient might be more likely to receive an ORIF given his sporting activity, but otherwise he's safe and ambulatory, meaning it's less likely that we might be able to do an operation for him today. So the next case is an 85-year-old who's got an extracapsular neck of femur fracture for a DHS. She was admitted before the previous patient with a neck of femur fracture, meaning she possibly should be done before that patient, case number 1. She's on a DOAC, but the last dose is probably long enough ago that she can have an operation today. But you can mention that, you know, if you could check hematology guidelines or discuss with a hematologist, especially if it's not entirely clear. Otherwise, she's ready for surgery. So the next case is a 56-year-old lateral thigh abscess in a diabetic patient. So we've found out that he's not septic, so he doesn't require an operation urgently, and he takes insulin. So based on that, there'd be an argument for doing him earlier to avoid fasting him for too long. However, he is on a sliding scale, so that can temporize things, and he's an infected case, so it might be best to wait for him to be done on the end of the list to avoid infecting the other patients on the list. The next patient is a 48-year-old with a native shoulder dislocation, which failed reduction in ED under Entonox, and the ED team weren't happy to sedate the patient due to his cardiac history. He's neurovascularly intact. However, since he has a dislocation, he's likely to be have his procedure earlier on the list. So the last patient has an extra-articular distal radius fracture, which is a week old. She's safe and ambulatory at home, but since the BOSE guidelines recommend operating on extra-articular distal radius fractures within 7 days, there may be an argument to prioritize her over the clavicle. So based on all that information, have a very quick think about how you might order this list, and in a second, I'll give you my order. So this is the order that I came up with. I put the shoulder dislocation first to protect his neurovascular structures. And then I went for the 2 neck of femur fractures with the patient who came first prior to the next. I would then finish the list with thigh abscess. I might be able to slot in the distal radius fracture depending on how the day was going. The patient can also be kept in reserve if any of the other cases had to be cancelled. I'd vocalized to the interviewer that it wouldn't be possible to do all the cases listed in the time allowed. So I'd therefore cancel the patient with the clavicle fracture and make sure he's been fed and planned for another day when there might be a bit more capacity. I think the most important thing to note about the final order is that it isn't as important about the actual order that you give as how you justify your answers. This is where you'll get the points. There probably isn't an absolute right answer for how the list is ordered anyway. You can always argue one way or the other. So thank you very much. I hope that's useful. Don't forget about the possibility of an on-call scenario as an alternative to this, and do practice, practice, practice. That's how you'll improve. Best of luck to you all.
Thank you so much, Matt. That was really helpful, really clear explanation about some of the common prioritization scenarios that you might have. And again, just emphasizing that there's no right answer. Just think about what happens in your hospital and provide a justification for it. The interviewers are looking for people who can think about and justify the reasons. So that's by far the most useful thing that you can say in the interview. So we're going to move on to Lisa now. Thanks again for everyone who's spoken so far, and thank you for asking any questions that you have. Please feel free to continue in the box as we go on to our last speaker. Lisa, over to you.
I think these interviews might just be a matter of aggregation of marginal gains. So lots of you will have heard about David Brailsford and how the GB cycling team focused on tiny, tiny improvements, taking hypoallergenic pillows on tour, painting the inside of the lorries that carried the bicycles white so that they could see any speck of dust, special fabrics for their clothes, figuring that it was little tiny things that would give them the edge. And I think it might be the same for you, because lots of you have got very similar experience. The context is going to be pretty much the same. The questions are going to be pretty much the same. So it's how you prepare and those little marginal gains that will really matter. So let's think about getting the physicals right first. Now, on purpose, I am in a hotel room in Edinburgh tonight, because I know that some of you will be considering using a hotel room for your interviews, because you've got heavy users of Wi-Fi at home, or cats or children. And so I've made it my business to set this up so it's good enough for me to be interviewed. The background isn't perfect, but it's good enough. I've set up the lights here, and I've not tied it up on purpose, but you can see I put the lamps so that they are coming at me from both sides, so the lighting's okay. Now for you, when you'll be interviewed during the day, and actually the very, very best you can have is daylight, ambient light coming from behind your laptop, not from behind here, because if you have light coming from behind here, your face will be in shadow. So you definitely don't want windows or lights. You want, if humanly possible, your laptop with daylight coming from behind your laptop or desktop. Now you can see here again, I've got my stuff set up on an ironing board, and I've got a box underneath my laptop. So my laptop camera is just on the level of my eyes. And you can see that my eyes are about a third of the way down my screen. And you can still see some of my torso and my hand gestures, and certainly all my face. So that's the best positioning. I've got a water bottle here, not a glass of water, because there's too much of a chance of me spilling that everywhere. And I have made sure, I've checked time and again, that my sound and my vision is okay. I've tested it out numerous times today. Sound is more important than having a perfect picture. So do make sure that your microphone is good enough. Now, I don't work for Apple, but the microphone and the camera in my Apple products is good enough. And I've compared it with loads of very fancy schmancy microphones and cameras, and nothing has been better than the ones I have built into my desktop and into my laptop. Now I am on a laptop here, and I would never do anything important either on a phone or on my iPad. It's not reliable enough. So I would always have a laptop or a desktop, and I would always have a second laptop with me, just in case there's a disaster. I'm relying on Wi-Fi here, and I'm anxious about it. In real life, when I'm doing an interview or being interviewed, I'm on a desktop that is connected via an Ethernet straight in. So I'm not relying on Wi-Fi at all. But if it all did go down, I've still got my personal hotspot, and I would try and rely on that. But I love my Ethernet cable that goes right from my desktop straight in, so I'm not having to rely on Wi-Fi at all. On the day of the interview, watch who is heavily using the Wi-Fi in your building somewhere. Streaming Netflix won't do you any favors, so be careful about that. Reboot the day before, and it's Cash that told me about that, because I think it was about 2 minutes before he was about to do something really important. Suddenly there it was with that little line going, 25 minutes. So I always reboot the day before. And when you're using Teams, use Chrome, not Safari. Thinking about making sure you're on time, just like for a real interview, being late is a problem. And we're not absolutely sure about admin on the day, but I would say to you, check that you can get in. And when I know that I've got to go in somewhere the next day online, I'll go in at 10 o'clock the night before. Nobody's going to be around, and I can just check that nothing unexpected happens. And I will then make sure that I am well in time. You might be put in a waiting room for a while. It might be that while you're being interviewed, you can see the next person in the waiting room. Their name doesn't matter. Just make sure that you're absolutely where you need to be, well in time. Camera angle, as I've said to you, make sure that you can, the people can see your torso and your hand gestures. You're not looking right at them, and your camera is on the right level, so you're not looking down at the interview panel, and also obviously having a double chin. That's not a good look. Now, what about blurred background? So you can see here, my background isn't great, but it's not terrible. It does need to be professional. So just watch out for what's in your background. I was teaching somebody the other day, and I could see his hairdryer next to him just in the background. And it was fine with us, but it might not be a good look for interview. Blurred backgrounds, be a bit careful of those as well, because there is a tendency as you move to go in and out and not be visible. And that is rather disconnecting. So blurred backgrounds, I tend not to be a massive fan of. Now, what do you wear? We had an interesting discussion about that at an AO Principles course today. And there was somebody who was probably a bit younger than me, but on the older side, who said, well, you know, I would expect people to wear a suit to interview. My view is that you imagine who might be interviewing you, think about the most formal person who will be interviewing you, and go up a notch. So if you imagine a scale, 0 wearing your underwear to 10 being in black tie, somewhere, I mean, probably about 8-ish, but certainly a step above everybody else. Think about solid colours. This is not bad for here's probably a little bit informal, but it's dark against a light background. What you don't want to do is to be on a light background wearing a white shirt and then be looking like a floating head. So think about what you're going to wear, practice wearing it, sit up straight, smile. I know Cronan Kerin doesn't smile that often when he's really concentrating, and so he can look a bit fierce. Have a little think about how you look when you're really concentrating, and really think about, certainly with those first few seconds, being careful to smile, look into the camera, so you at least look as though you're making eye contact. Nerves. I just do get nervous, and I get anxious about people looking at me, and you know what? I'm never going to get rid of that. So I know that I must avoid Coke, a cola, avoid drinking coffee or tea. I just can't do it. I've had a banana tonight. I had it about 20 minutes before we started. I always put a little bit of lip gloss on the front of my teeth so that my lip doesn't get stuck on my dry teeth because I get so nervous. And on the run up beforehand, which is when I start with my self-talk potentially of, oh no, what if I can't remember anything? What if I sound really stupid? What if I freeze? I get rid of all those negative thoughts and think in my head. First of all, I start counting backwards in sevens from 535, 528, 521. So the logical side takes over of my brain. I get back under control, and then I see myself in full flow, whether it's interview, teaching, whatever I'm doing, I see myself and look at whatever's going on, seeing everything just going swimmingly and going hunky-dorily. And I do not allow any of that negative self-talk in. Listening to the presentations before, you can rehearse your stories. And that's what it is. You are going to have a bunch of stories about your unique selling point, your superpower, the things you feel passionate about, your examples, and you're going to polish those up. And remember, my dad always says, tell us how big the fire was, not where you bought the matches. So you polish up your great stories, you practice them, you have a few Post-its, and here, so that I don't have to panic that what if I forget what I'm going to say? I've got my Post-its here, so I can just quickly look at them if my mind went a complete blank. And great points about structuring your answers. Structure your answers. And I really like that idea of coming back to a final sentence that answers the question beautifully. And then at the end of the section, you stop and you log out quickly. Do not hang around because time is of the essence. So, excellence interview is not about fabulous radical changes. It's going to be about marginal gains, little things, attention to every single detail. And you saw with Mark at the start, went a little bit wrong with his visual aids, but he just stayed calm and it's sorted out. So have plan B, have plan C, stay calm, and good luck to you. Thanks.
That was brilliant. Thank you so much, Lisa. Really, really fascinating talk, and so important to take on board all of those marginal gains. I think it's something that we can all think about, whether it's this interview coming up in a month's time or any others that we might have coming along in the future. That was the last of our talks. I think we've managed to take on board most of the questions that people have asked already so far. So please put the last ones in as we tie down this OrthoHub webinar. I'd like to say thank you again to all of our speakers tonight, Mr. Mark Crowther, Mr. Cronan Kerin, Paddy Lancaster, Jawaad Saleem, Matt Hague, and Lisa Hadfield-Law. Thank you so much for making this such a useful evening. Seeing that we've had over 100 people taking part in the webinar, and actually no one really is left throughout the whole thing, which has been brilliant to hear that it's been so useful for everyone. Thank you to everyone at OrthoHub for helping us host this. And I would like to point you in the direction of our next podcast coming out with Research Pros, Dan Perry and Matt Costa on, and that's coming out next week on how to win friends and influence P values. So on that bombshell, thank you once again. Best of luck with the interviews coming up. And we look forward to seeing everyone back at OrthoHub in the near future. Thanks again.